Good morning, everyone. Welcome to the eighth annual virtual Aphasia Awareness Conference hosted by Just Ask. We're really excited to see you all here this morning, seeing lots of chipper faces. We have a great layout set up this year, and the exciting part about this year's conference is the topics were picked by many of you. This year's conference theme was supported by people who completed last year's survey and who told us what you guys want to talk about. So we're really excited to have our lineup of guest speakers. Before we dive into introductions, we are going to open up with a video from one of our sponsors. So I'm going to have Dina share that with you all now.
June is Aphasia Awareness Month, a time to help educate the public about aphasia, a communication disorder. The Rhode Island Department of Health congratulates Just Ask on its 8th annual conference and commends its ongoing efforts to raise awareness, provide education, and support individuals affected by aphasia and traumatic brain injury across Rhode Island. We recognize Denise Lowell and her team, survivors, families, clinicians, and advocates for their dedication to this cause. Congratulations on this important event and on your continued leadership to support our community. Thank you.
Well, as you know, each session throughout the month will be recorded. We prefer to have you on mute during the presentation. You are welcome throughout the presentation to type in any comments or questions in the chat. And then at the end of the presentation today, we will have a Q&A section. At that time, during the Q&A section, we will stop the recording, so no one's face or voice will be recorded, and you're welcome to share any thoughts or questions as a part of a group discussion at that time. So that will be at the end today. If we have any professionals with us this morning, we will be sharing a certificate of completion in the chat. I will send it as a file in the chat at the very end of the Q&A session today. With that, you are welcome to download that and keep it as a personal tracking for professional development hours for your professional association. So if you have any questions about that or need any support with that, you can reach out to me directly on the chat or via email, which I will put in the chat. I think that is it for housekeeping items.
I'm not sure if we said this. We said that the recordings that we are doing, when we come to doing Q&As, a lot of the information, I don't think some of us would feel comfortable having that recorded. So our Q&As will be non-recorded. We'll shut it down so you could ask these questions, and it won't be recorded. But if you want to ask questions and you're okay, the photos that your questions you're asking, that means that you're giving us permission to have your visual on the recordings. If you don't want your photo on or your picture on any of our recordings, please unface you. I don't know what that word is, but include yourself so that you're not recorded. So again, my name is Denise. Welcome to our 8th annual Aphasia Conference. This conference has been the growth of Denise increasing her life of becoming more independent. I had my stroke almost 11 years ago, and one of the resources I really needed was to learn more about something I didn't sign up for. I didn't want to have a stroke or a brain injury or live with aphasia, and it came to me, and I didn't have the resources and education I needed to figure out what the heck is going on. So all the resources and webinars were very expensive, and at that time, I couldn't afford it, and what they were telling me was over the top for me, and I couldn't process it. So when I became to improve a little better, I said nobody should have to pay to go to a webinar or to learn about a disability that they didn't sign up for. So that was the growth of Just Ask. And I'm so happy that we've continued to do this. And now we do it virtually so we can share this education around the world. And it is there for you to come back and look at again. The topic this year was something like Kate said, this is a topic that people asked about. They said it's kind of taboo. They want to talk about it, but sometimes it feels uncomfortable, and it feels uncomfortable for our care partners. So I took the challenge and we're doing it. So we're going to talk about it. We're going to talk about everything that happens about living our life, having a stroke, having a brain injury, and living with aphasia. As I what I've learned last night, my granddaughter's graduated, and we're all on a stage of our journey that sometimes we agree and we move on, and sometimes our journey provides us in a direction that we have to follow in. So this is what we need to learn about. This is where we're at, and how can we make it as independent and successful in our life? And so this topic is going to be amazing. And it can't, we still don't charge anybody to do these services. So I want to thank the Nursing Placement Health Concept Limited and the Rhode Island Department of Health for making this successful and making this happen for all of us. Once again, thank you all, and I'm going to turn it over to Kate.
Awesome. Thanks, Denise. Okay, this morning, our gracious guest speaker is Sachi Paul. She is a clinical psychology PhD student at the University of Pittsburgh with a focus in neuropsychology. She currently works in the physical medicine and rehabilitation department, seeing individuals across both inpatient and outpatient settings. And her heart lives at the intersection of brain injury, mental health, and meaningful recovery. So we're so excited to have Sachi joining us this morning and giving us an overview of some of those kind of taboo topics and comorbidities that come along with brain injury often, like mood changes, talking about attention, emotional regulation, medical or medicine considerations, and other treatments for mental health. And so, Sachi, at this time, I'm going to go ahead and pass it over to you.
Sounds great. I will share my screen.
Awesome. Thanks for being here with us this morning. We're so excited.
Thank you. I'm very excited to see everyone. I know it's early. I'll try to keep this as entertaining as possible. So good morning, everyone. My name is Sachi. Thank you for the very warm introduction. And thank you so much, Denise and Kate, for having me today. I feel very excited and very honored to be joining you guys. As you might have already heard, I'm going to be talking a little bit about mental health and kind of these like cognitive changes after brain injury. I'll go a little bit more into aphasia specifically, and then also some more broad information about brain injury as well at the beginning. And as Kate and Denise said, I'm a graduate student in the clinical psychology department at the University of Pittsburgh, and I'll talk a little bit more about that as well in the next couple of slides. Okay, so see if okay. So I decided to first start just by why are we talking about this, which I think Denise did a very beautiful job of touching on already. But most importantly, it was chosen by you all, which I think is, the most important part about this conference, and something that I feel is very unique and exciting. Secondly, while mental health seems to be a lot more discussed in the last 5 or 10 years, maybe, 15, 20, which is awesome, it still is considered a very taboo topic. especially depending on what community you're most part of, right? So depending on where you live in the US, depending on whether you're in these more like academic or clinical spaces, or maybe in less urban environments, it kind of all depends, right? And last month, the CDC actually published a paper talking about how mental health stigma can take many forms. And this was just a couple of weeks ago. So they talked about number one, this sort of like structural stigma. And here you can think about laws, regulations, policies that all kind of limit the rights of people that are struggling with mental health disorders. We can also think about public stigma. So this is kind of these negative attitudes and beliefs from individuals or groups of people that are targeted against, against or towards people that are struggling with mental health. And something that I don't think we think about as much is this idea of self-stigma, right? So this is this idea of just blaming ourselves and kind of believing, okay, like I'm a flawed person or there's something wrong with me. And that's why I'm really struggling. So maybe I don't deserve mental health care. And this can look a lot of different ways. I'm sorry, some of these slides have a lot of text, but I'll go through them verbally. So this is just a graphic that I found recently, kind of going over all of the, some of the many possible ways that mental health stigma can look, right? So things like everyone has anxiety, some people are just stronger than you are. Um, Therapy and medications are just scams. You don't need all of that. Um, what do you mean you can't get out of bed? It's not like your legs aren't working, and so on. My favorite, all women are a little bit bipolar. Thanks for that. So anyway, we hear these things all of the time, unfortunately. And this isn't new. So the AAMC also this year just came out with this article about mental health care and mental health issues in society with the headline, "This isn't new and it's getting worse." So you can think about from 2008 to 2019. So that's, about a decade. The number of adults aged 18 or older with any mental illness increased by nearly 30%. So that's a really whopping kind of scary number. We know that the pandemic has further exacerbated mental health issues, anything from depression, anxiety, social isolation, thoughts of suicide, all of these things. And while progress has been made to reduce the stigma around these issues, the problem really persists. And I thought it was really striking that the last line of this is sort of stating that having these issues prevents many people from accessing care. So, kind of thinking about just the stigma alone is such a barrier to accessing mental health care. And then we know, so this is a recent survey that 7 out of 10 brain injury survivors and their caregivers report that their mental health is worse. So this is worse than before, so pre-injury, and also caregivers pre their partner or child or whoever having that injury. And anxiety and depression are really, really commonly reported things. Okay, so that was just a little intro to why I think this is really important, probably telling a lot of you what you already know. So let's talk about it. I'm happy for people to ask questions at any time. I think people will be moderating the chat for me, but please feel free to jump in at any time. Okay. So a little bit about my background. I thought this might be helpful just knowing where I'm from, where my perspective comes from. Um, so oops, let me see if I can. Okay. So I grew up in Austin, Texas. I was born and raised there. My parents actually immigrated here from India like 45 years ago now. So that's the cultural background that I come from. I spent a lot of my life in Austin until I went to college in Houston, Texas, at Rice University, where I was a cognitive science major. And I joined my first research lab focused in post-stroke aphasia midway through my college experience. And I really loved it. I just got to work with research participants coming in with aphasia, and we did a variety of very painful, probably neuropsychological tests. And I loved this experience. I didn't really know what I wanted to do. And then I went over to Georgetown University Medical Center for 2 years of a post-bac after my undergrad degree. I worked at a very large aphasia research lab that I loved dearly. And I also then decided to apply to graduate school. And I'm now at the University of Pittsburgh. I actually really despise the cold weather, so I don't really know why I moved so far. However, I'm here now. I'm in my fifth year in my clinical psychology PhD. Clinically, I'm very focused on mental and cognitive health recovery after brain injury. So in my program, we do 2 full years of working at our community psychology clinic, where you see kind of just a variety of clients in the community. And after that, you get to choose rotations. And so I've since been choosing things that are focused on brain injury and recovery. Um, my research is in reading after stroke, so I'm pretty focused on what happens to the brain with language and reading after somebody has a stroke. Um, I hope to be a neuropsychologist in a couple of years and focused on aphasia after stroke. So yeah, you can see I've been in the aphasia space for as long, yeah, for my interests have been there for a long time. And so this will be where a lot of my talk covers in that space today. Okay. So a little bit of plan for today. I am first going to talk a little bit more broadly about why mental health challenges are common after brain injury. So I just told you that they're common in general, but why maybe more specifically they're even more common after injury. I'm then going to get a little bit into why they are hard to talk about and treat. Um, and then go a little bit into what the research is showing us. And then the last part of my talk will be focused in some therapeutic approaches and strategies that I think are seemingly very promising. Okay, so a little bit of what I like to call core foundation here. So this is just sort of laying the groundwork for this topic. Firstly, I think it's an important thing to acknowledge that mental health is a part of your physical health. It's not your personality. I see a lot of clients come in saying like, "Oh, I'm an anxious person. That's just who I am." Or, "Yeah, I'm sad all the time. That's how people know me. That's who I am." This is a part of your physical health, and I think it's something that our field does a really poor job at emphasizing to people. So we don't treat mental health care and appointments and regular checkups in the same way that we treat physical health. And I think it's only in recent time that we're seeing how detrimental that's been. Second is you don't ever need a diagnosis to be having a hard time. So some of you may have heard of this big psychology holy grail called the DSM. It's the Diagnostic and Statistical Manual for Mental Health Disorders. I would say it's very argued upon, but is sort of the standard treatment of care of how we give people mental health diagnoses. In this book, there's probably every diagnosis you could think of, and maybe more that you've never heard of. And there's a huge list of criteria, and a person has to meet a certain amount of criteria to have this diagnosis. Sometimes people come in and say, I've never met full criteria for something, so I don't think I have anything, and I don't know, maybe what's wrong with me. And I think it's really important to remember you don't need a diagnosis to be having, some of these symptoms or having a hard time with some of these things, some of these days, and stuff like that. And as I've mentioned, brain injury automatically makes you more vulnerable to mental health disorders, not because of who you are, but because of what your brain has endured, right? So our brains are resilient, they're strong, they recover, as many of you know, but because it's putting in all of this extra effort already into some things that might have been easier for you before, it's, even more of a task to be able to, yeah, kind of be doing everything at once. Um, in addition to things that impact mental health, so I put a little image on the side here. I don't know how visible it is, but typically in psychology, we think about a lot of things when we're thinking about mental health, right? So, did you have like early life trauma or early life experiences, genetics? What was the setup of your family? Have you had social support for a long time? Have you had access to mental health care services? Have you had, neighborhood schooling opportunities? What has your lifestyle looked like? And I could go on forever, right? So in addition to all of these things that impact mental health, I think we often forget about the role of neurobiology. And so neurobiology is of mental health specifically, studies how the chemistry of your brain shapes your psychological well-being, I'll call it. So we know that a lot of mental health disorders and illnesses are involve these kind of altered chemical states of your brain, right? So the way that chemicals in your brain communicate with each other shifts a lot in these mental health disorders and also after brain injury, right? So you can imagine that all of these chemical shifts really directly impact things like behavior, mood, cognitive function. And sometimes these things are not easily rebalanced or recovered, right? So we see this sometimes taking weeks, sometimes months, sometimes years, and sometimes it's just a constant journey of a work in progress, right? Um, okay, so you might be thinking, what are some of these mental health challenges that you're talking about? Um, Okay, so I will go down this list and I will touch a little bit more in detail about some of them in the coming slides. Um, so first we have depression. This is probably the most common and well-known, what most talked about. Depression affects 1 in 3 stroke survivors. And it's, most known for just this feeling of like sadness and hopelessness. We also have anxiety, which affects almost half of people with aphasia. And this is sort of mostly characterized by this like worry, right? So you're very like fearful and worried about something or about many things. Okay, we also have apathy, which affects about 40% of people after brain injury. Um, we know apathy to be this sort of like lack of care or ability to like express strong emotions really in any way. Oftentimes, caregivers or providers or even folks themselves with apathy sort of describe it as like, I'm feeling lazy, or a caregiver will be like, they're not moving, they're not getting up, they're just kind of lazy. And this is a really, really bad common misconception that we have, I think, with a few of these things, right? So it's not really about laziness. It's again about these chemicals in your brain and your environment and recovery and all of these things. But it's characterized by this kind of lack of ability to express strong emotion. Okay, and then we have fatigue, which I just said is universal. I very rarely have people coming in saying, yeah, I feel high energy and awesome. This is really hard. And I think in the world that we live in today, it's just increasingly hard in general to manage all of the things we're expected to manage. And after brain injury, fatigue is really, really, really frustratingly hard, I think. Um, Along with irritability and emotional changes. So we see this also in about half of stroke survivors. So this is kind of just, I'm not feeling like I used to feel. I'm not reacting to things in the way that I used to. I just feel, really frustrated really easily. Okay, and then we have pseudobulbar affect, which I actually have a slide on after this because I usually get a lot of questions about this. But this is sort of this really sudden, uncontrollable spell of laughing or crying. Yeah, so I'll talk about this a little bit more, but it kind of is just this, people come in and they're like, yeah, I just immediately started laughing in this situation that wasn't funny at all. And I didn't know how to control it. Okay, and lastly, I'll talk a little bit about some cognitive difficulties and this general confusion, again, which affects, a really large majority of brain injury survivors. Oftentimes, it depends where in your brain your injury was, but it's really, really common. Any questions? I know I'm moving through material.
We have a few in the chat, but we will probably go back and address them at the end, Sachi, but this is
Okay.
wonderful. Thank you. And
Sounds great.
if we could just slow it down just a touch, that would be lovely too.
Sounds
Thank
good.
you.
Thank you.
This is great. Oh, I did just want to address, we did have somebody ask about the slides because this has been a wealth of information already. And just a friendly reminder that a recording of this presentation will be posted on the website. So you will be able to see the slides and hear Sachi talk about each one starting in July. They will all be posted after the conference.
Yes, happy to share anything also. Of
Thank you.
course. All right, so I'm going to get a little bit into some details about a couple of these that I thought might spark some more questions. Um, the first one being pseudobulbar affect. Sorry, this one is a little bit text heavy. So this again is this episode of just this like involuntary crying or laughing when it feels sort of inappropriate given your mood or given the situation around you. So again, clinically, people report this kind of loss of control of emotions. So it's really difficult to stop. I need to wait it out, or I need to remove myself from the situation. As you can imagine, this can cause really significant distress and also come with a lot of shame and embarrassment. Typically, we see this most impactful in people's social lives or in their work lives, right? And this is because these are times when people are connecting with others. And so I think having these sort of involuntary episodes can make it really hard for someone to still feel like they're present and contributing in this social setting. So we also call this PBA. It's thought to result from lesions to your frontal lobe, which are very common in injury, or these other relevant pathways that are known to regulate emotion. A lot of times we see this very early on, so in kind of that sudden acute phase of injury. As Kate or Denise mentioned, I currently work in an inpatient setting. So that's right after injury, and we see this a lot. there is like medication for it and treatment. And so, and it occurs, secondary to a lot of neurological conditions. So Parkinson's, dementia, MS, not only stroke. But this is something that has medication and treatment, but it can be really frustrating, especially when it lasts, into the chronic phase beyond your injury. Okay, and attention is another big one. So I'm not going to go into the details about this figure, but it is a research paper that recently came out a couple of years ago. And it basically says there are a lot of types of attention. There are a lot of characteristics about your brain. So where your lesion was, what the connections between parts of your brain look like now, and things like that. There is a wide spectrum of language recovery. And then there's all of the factors of your environment. And we know that most folks with brain injury report difficulties with attention and also executive functioning, which I'll talk about in the next slide. So attention is kind of our brain's way to limit what we're focused on. So focus on one thing and maybe try to ignore distractions and things like that. It can be really hard for a lot of people, right? So ADHD is also a really growingly talked about diagnosis these days, which is also a disorder of attention. Um, when we think about attention in the context of brain injury, we think a lot about the frontal lobe again. So this frontal part of your brain, it accounts, I think, for about a third. So it's about 40% of your brain, and it accounts for a lot of brain injury because of its size and where it's located, right? And so we talk about this thing called frontal lobe vulnerability, which is again just saying due to the frontal lobe size and location, it's very often damaged when we have a brain injury or a stroke or these kind of disrupted pathways. This can be really frustrating. So issues with attention, I think, feel hard for anyone. And like I said, in the world that we live in, when we're, oftentimes so used to multitasking or like being in a conversation and doing something on your phone, it can be really hard to do multiple things at once. So I oftentimes tell people, give yourself extra time, which I'm sure people have heard before. Write things down, and I like to tell people to write things down in micro steps. So I recently had a client come in telling me, I've been making lists for myself. I tell myself to do the laundry. I open the detergent and I just leave everything out. Like I forgot to put it in the laundry machine. And I really try to encourage micro steps. So this is like literally writing down, I need to get the detergent, I need to sort my clothes, and kind of breaking things down, which I think really helps with this sort of challenge with attention and executive functioning. I also often recommend body doubling. I do this with non-brain injury folks as well. So just people struggling with attention in general. The typical college student I have come in, I'll be like, okay, you need to study and you can't, like go with somebody else and have study in front of them and make them study too, right? So it's having two of you or three of you or a group of you doing the same thing. And it's kind of this practice of accountability that I think can be really important. Okay, and kind of related, you don't really need to read all of this at all, but I put in this little brain diagram just to show you the large scale of the frontal lobe that I talked about regarding attention. It also is home to a lot of what we know as executive functioning. And executive functioning is kind of your brain. I like to call it the like air traffic control system. So it's this set of like high level processes, right? So you're managing thoughts, emotions, attending to things or focusing attention on things, managing time, impulse control, monitoring yourself. So it's a lot of things. And you can imagine you're like, Sachi, this is applicable in everything that I ever do in life. Yeah, it kind of is. And that's really hard. And so some examples of executive dysfunction, which I put on the right side of this slide, include like being very easily distractible. So, I can't focus on this message. I'm doing this other thing, or I'm looking out the window. Um, Focusing too much on just one thing. So daydreaming when you shouldn't be. So again, kind of just this like lack of being able to focus on the thing you want to be focusing on. Um, Struggling to switch between tasks. Impulse control, this can look like a lot of different things. We see it with like alcohol, gambling, substances, but also just, you are, or you're eating dessert when you don't want to be, or you're staying up late watching TV when you want to have a stable bedtime routine, right? So this can look a lot of different ways. And also trouble starting like maybe difficult or boring tasks. So it's just like things you don't really want to do. They're kind of on the back burner. And it's just hard to initiate or start that. Okay, so as you can imagine, it can be very difficult to live with challenges in all of these things, right? So we kind of covered mood regulation or being, having these sorts of uncontrollable moods, this issue with attention, and then, this sort of traffic control system of your brain. So, like impulse control, task switching, things like this. I'll talk a little bit more about the depression, anxiety stuff in the next coming slides. But yeah, so you can imagine this is very difficult to live with. But also, it is associated with a lot of things, such as worse outcomes from rehab or therapy. So you can imagine not really being able to fully engage in rehab or therapy when these things are hard for you. A lower quality of life. So in psychology, we talk about quality of life as the way someone perceives their own quality of life or their overall well-being. So yeah, so this is coming from people themselves. Like, yep, life is kind of hard for me. I can't really function very well. We also see this being associated with higher healthcare costs. And not to be too dramatic, but higher mortality, right? So you can imagine someone's feeling depressed. It's harder to get yourself to be moving, or to do things that are meaningful for you, or to, pursue social connections that you want to. And you can see that might lead to more depression and the cycle continues. Okay. So these are things that are very, very grateful or very, very impactful. Um, and yet, there is a lot of shame around all of these things. So, unlike physical health, right? So when someone has a physical health problem, I think typically people's responses are of, fear and worry and concern for this person, like, oh my gosh, you have a tumor, or oh my gosh, you had a fall. Whereas we see that mental health issues and cognitive health issues, um, are just as severe a lot of the time, and we don't really still have the same response. Okay, so over the past couple of weeks, in preparing for this, I asked my own therapy clients to tell me a little bit about shame that they feel around seeking treatment or about struggling with some of the things that they're struggling with. And I got a lot of answers that I'm going to share with you. So, one of the most common things that I hear now, especially working with people with brain injury, is I should be grateful I survived. And in the same vein, I'm still blessed. This is my second chance. Okay, I heard a lot of my partner is already doing so much work for me. I want them to enjoy life too. My friends told me I'm not one to give up, which is true, I think. This is specifically with from someone with aphasia. So I was so focused on getting my speech back, I feel like I had to live with everything else. So kind of just saying it was too much. I had to put my depression on the back burner because I needed to figure out how to communicate, which was functionally impacting my life. And I didn't think my depression was impacting me in the same on the same level. Depression, that's just not who I am. So that's not my personality. It's never been. I don't want to let my kids see that things are hard. Their lives are hard enough. I hear this very, very frequently from parents. And lastly, I just can't turn into someone that nobody wants to be around. So I hear a lot of this sort of, I know people that complain all the time. I can't turn into that person. Like that person is annoying or that person is a downer, and I don't want to be that way. Okay, so the response I hear from clients all the time is something along the lines of, I need more willpower, or I need more strength, or I need to be stronger in coping, or I need to be grateful. And I'm here to tell you, I don't think that's a great attitude. I think that you need more support. And this is like a soapbox I will die on. We know that after formal rehabilitation ends, people with aphasia often return home to watching a lot more TV than they used to, leaving the house, 1 to 2 times per week, maybe more for doctor's appointments, and losing a lot of friendships or having to kind of re-navigate what your role in a friendship looks like. So we know this. This has been published time and time again. It's been surveyed by, it's from people with acute stages of aphasia. So they're, just leaving inpatient, they go back home, and it's this kind of time to re-navigate life, right? Which lasts for months and years. So this is a predictable outcome, as I like to say, in a system that hasn't built enough ongoing support. So I think we do a really, really poor job of preparing people for the transition that comes with going home from the hospital. Um, we know, again, that brain injury increases susceptibility to mental health conditions. And yet, in most hospital discharge paperwork, for people that I see with aphasia, for example, it'll say like stroke neurologist, follow up in 2 weeks, mental health provider if needed or if family sees fit. Um, no idea how a family is really supposed to recognize if that's something that someone needs right now, right? That's hard. And families are also dealing with, juggling all of these consequences of going home and again rebuilding this life, right? Um, so we also oftentimes think about, am I having a reaction to what happened to me? Am I adjusting? Is this just an adjustment period and I'm crying now and I won't be crying in a year? So kind of like, should I just stick it out? Or is this really, a direct neurological effect? Um, My answer to this is that this is interesting for clinicians, and it doesn't really matter for care, right? So we're providing the same mental health care regardless. So I'll go into that a little bit more. But there are these large themes that we focus on in psychology. And the etiology or the beginnings of where this stems from doesn't really matter, right? I mean, it's important, we care about it, but will it affect how I treat you? Probably not. Um, and so the reality is, even someone with really great support and a positive outlook can struggle. And in fact, we see this all the time. Okay, so I'm going to move into talking a little bit about cycles. I call these the vicious cycles. This is something we talk about in the psychology world a lot. But I'm going to give you a few examples about what I mean by this. Okay, so we can see here. So this is what I call a vicious cycle. Okay, so it's kind of this like self-perpetuating loop. So let's imagine someone with social anxiety. Okay, so they're experiencing this fear, like racing heart, thoughts of nobody will talk to me, people will judge me, as they're preparing to go to a party that their friend invited them to. So, in response to all of these thoughts and feelings, their behavior is that they will decline this invitation to spend time with friends or loved ones or any, even strangers at this party. And we can see that going into isolation, um, spiraling more about challenges being in public, maybe dreading the next opportunity that you'll receive an invitation and have to do the same thing over again, leading to more social anxiety. Okay. So we can see that this could be a cycle that lasts a very long time. And it's kind of self-reinforcing. So you're sort of reinforcing this psychological distress rather than resolving it in any way. Okay, and now for the cycle on the right side. Um, so communication, we know directly affects mental health. So difficulty with communication, right? With the number one reasoning being, social connection is very important for mental health, and that can be kind of hard with communication difficulty. So, both communication difficulties and mental health can affect a lot of things. So, identity, so who you see yourself as, participation, so just life participation, motivation, and your social relationships. And all of these things affect your mental health. And mental health, we know, affects communication. So we know that when people with aphasia are feeling more confident or comfortable in a situation, um, their communication is typically better, right? You're feeling less of the pressure and the fatigue. And when your mental health is not feeling great, it impacts communication. And again, you can see how this cycle continues and continues in this kind of negative loop. Okay, here's another cycle that I think we don't really talk about enough, which is grief. Um, so on the bottom right side, this is not really important to read, I don't think, but this is kind of the classic 5 stages of grief model. So it talks about denial, anger, trying to kind of negotiate or reversing this loss that you had. this kind of really deep depression or hopelessness, and hopefully acceptance at some point. So coming to terms with loss, and kind of finding a new way forward. So here's another myth that grief is about death. Okay, I'm here to tell you that is not how we like to view grief. This is another topic that comes up a lot in my clinical practice. We can think about grief in a lot of ways, right? Broadly, we view grief as a response to loss. And it's something that, comes in episodes. So it can come back every time you're reminded of change or of what used to be or of your relationship with, another person or yourself or your job. Some of the things that I think I work on a lot in grief work with clients is grieving language. So the ability to easily express myself like I once did. Roles. So your role as an employee, as a manager, kind of just in this working space, as a parent, as a partner, and as a friend, right? So it's not like you're losing these relationships necessarily, but they shift, right? So maybe someone's expectations for you change, or the level of what you could do before changes. um, Activities I once loved. So sometimes we work on building like new hobbies and new activities, but it's okay to be still sad about things that you used to be able to do, right? And more broadly, the version of myself I knew before. So I put this picture of glitter on the bottom left of this slide. I had a friend recently tell me about this grief and glitter analogy that she learned. But glitter, scatters around everywhere, right? So it's all over your things, and you kind of can never clean it up. You can vacuum and clean everywhere, and a few years later, you might still find a piece of glitter in a piece of your clothing, right? Um, and this is kind of a way to think about grief. So it's scattered around. It can impact a lot of things in your life. It can be kind of everywhere. And it's hard for that to go away. Um, and sometimes, it's nice to see it again. It's like catching light, and it reminds you of something special that you had. And other times, it comes with these really difficult negative feelings. Um, but yeah, I think that focusing on grief is something that uh, either, we don't do enough or are not well enough trained on how to deal with in a non like death setting. Okay. And then the cycle of thoughts. This is the last cycle I'm going to talk about. You're like, Sachi, when are you going to tell me how I can help these things? And I am going to get into that shortly. So the cycle of thoughts, we know that negative thoughts can become self-fulfilling for anyone, right? So this is just the human experience. Um, for people working on communication, this is especially true. And again, like I said, we know, and many of you know, that feeling anxious, ashamed, and discouraged can make speaking a lot harder. Feeling hopeful, relaxed, confident, can actually help a lot. But how do we get there, right? So we know that people with aphasia, time and time again, are reporting that their emotional needs are not being met, whether that's from partners or families or society itself. So here's where I'm going to shift a little bit more specifically to aphasia. Of course, this is a little bit more of where my background is, and I think also well tailored for today's theme and audience. Um, so shifting gears a little bit to the research about aphasia and mental health. Unsurprisingly, there's a pretty large gap in the literature. So people with aphasia are excluded from, over 70%, so a large majority of studies on post-stroke depression. The reasoning behind this, I think, being a couple of things, but predominantly, depression is often assessed with these standardized verbal questionnaires that we give in clinical settings all the time. I think more recently, these sorts of questionnaires are being more adapted into things with visual icons, but that wasn't the case for a really long time. And so you can imagine giving these questionnaires to someone that's in the hospital is going to be very stressful and hard. But even later on, when verbal fluency is an issue, surveys and screeners that we had were not really well adapted. So again, most research focuses on the first few months after stroke. And we know that in the chronic phase of aphasia or injury, this is when people are adjusting the most to some sort of new normal, as I like to call it. So, if you're looking 6, 8 months, a year, however long it's taking, recovery is long, readjusting is long. And I think this is a time period where as clinicians, we're really dropping the ball on, again, like following up with people at these time points, right? Which is really problematic. Okay, so this is a recent study that I was involved in with some colleagues from Georgetown. So we looked at 92 adults with chronic left hemisphere stroke and a history of aphasia, as well as 70 adults without stroke. And we measured a lot of things through questionnaires that were adapted. So they came with images, and we let caregivers help out, or a speech pathologist helped out. And so we measured depression symptoms, stroke-related disability across a few domains, language impairment, and physical impairment. And our goal was to understand what exactly predicts depression in this population. Okay, and so there's a couple of main findings from this. Number one is that stroke survivors had significantly higher depression symptoms than controls. Okay, so that was baseline model number one. We can also think about the fact that these people came in for research. And so, you can imagine it's difficult for someone who has significant depression to even enroll in research. But still, we saw that there was this clinically meaningful difference between stroke survivors and folks who had not had a stroke. And we know also that this persisted well into the chronic phase of stroke, right? So all of the participants in this study that had had a stroke were, 6 months or greater, or a lot of years out from their stroke. And this was still something that we saw over and over again. So first of all, should we be thinking about adjustment as a longer process, perhaps? So kind of what I've been getting at over the last whatever amount of minutes of my talk, right? But I think people feel a lot of burden on themselves to recover faster, or to grieve their past life faster. Or why am I not, speaking in the way that I want to, or things like that, right? But clearly, a lot of things are still remain in this chronic recovery period. So now we wonder what did and did not predict depression. Okay, so I'll walk you through this. So starting on the left side, we saw that physical disability actually did not predict depression. So this was a sample, again, of left hemisphere stroke survivors with aphasia. But we did not find a relationship between physical disability and depression. We also did not find a relationship between aphasia severity measured by the Western Aphasia Battery, which many of you may be familiar with. That's one of our most standardized measures of like diagnostic measures of aphasia. It's largely a test of speech production. So there are a lot of like name this object, complete this sentence, repeat the words I'm saying. So its full measure is very speech production focused. And so again, we did not find that that was related to depression. What we did find was a couple of things. One being self-perceived communication and cognitive disability. Um, so this is questions about how you feel like your thinking is, or like you're communicating with peers or in your environment. Social participation, so connecting with others, or being involved in clubs or hobbies or things that are meaningful for you. And self-perceived recovery. So this is a measure of how do you feel like you're functioning? Are you where you want to be? And so again, these sort of self-perceived measures of language, connection with people, and recovery, we found all of those to be significant predictors of depression. And something that I found very striking about this is where I have circled here. So this clinical measurement at the top, the Western Aphasia Battery, is a measurement of language impairment. So what is happening? What is a test showing when we're in this controlled environment, right? So all of these people with aphasia did this test with a speech pathologist. And it measured, their objective abilities in all of these things. Um, and that did not predict depression, but how someone experienced communication difficulty in their daily lives, that affected depression. I'll let that sit.
Can I jump in and ask?
Yes, please.
Some of the research and stuff I've learned in the past is more mild aphasia usually indicates more depression. My data may be off of my research, but I've seen that sometimes that's more chronic. And maybe the data's changed or your resources changed, but that's something I've seen over the past couple of years.
Yes, that is actually, yes, that is still where what research is showing now. Um, I'm not sure exactly what the cause of that is. I've had thoughts of maybe we don't have great measurements for people with more severe aphasia, or maybe it is, your aphasia is more mild and you're more attuned to these issues that you're having. So it could be a number of things, but yes, we have been seeing that is the short answer, pretty consistently. Yeah, it's a great point. Yeah, so from this study, as a neuropsychologist in training, the field, I think, thinks a lot about the differences between what happens in a testing room and what someone is actually living with every day. And those are very different things, right? And tests tell us a lot, and they're very informative. But there are these differences that I think often get lost on clinicians sometimes as we're just chugging through tests and clients and not really thinking about these really significant differences. Okay, so from this study, first of all, we learned that for folks with aphasia, with chronic aphasia, cognitive and communication experience, social connection, and sense of recovery are primary drivers of depression symptoms. These also just so happen to be targets for intervention, and they map very well onto, currently existing therapies. But most of you have likely heard of or experienced this very large gap in mental health care. Um, so there's this growing consensus, thankfully, that interdisciplinary, so mental health care should be standard in aphasia rehabilitation. So not just an add-on, right? So like I talked about before, we should be including check-in with this provider in 2 weeks or in a month or, at a concrete time frame, which we do give for physical health appointments. Um, there's also been a lot of talk of this sort of stepped care model. This is actually from the UK, but essentially talks about considering what people need emotionally while they're still in these acute phases. And to be able to efficiently use resources that we have, to kind of, again, just adequately direct people to where they need to go. Maybe doesn't sound so profound, but it's not really how our system works right now. So it's great that this is in talk, right? But again, access is limited. Um, and most mental health providers really lack training in working with communication disabilities. Um, and I'm witnessing that firsthand now as I move through my psychology training. There's been a pretty significant number of speech pathologists who are now being more and more trained in this like mental health counseling. So kind of a movement in the speech world to say, okay, we already know how to work with people with communication disabilities effectively. So why don't we add on this training? And I have not seen as much of a movement in the psychology world to say, okay, we have this great mental health training. Why don't we add on training for communication disabilities? And I think that is very unfortunate and hopefully something that's changing. But again, something to think about. Okay, so I'm going to now talk a little bit about treatment, if that's okay with people, after I've given you this whirlwind of information. I'm going to talk about what I think has been a very effective approach to therapy with a range of clients that I work with. And that is called acceptance and commitment therapy, or ACT. So ACT has been increasingly adapted over the last 30 or 40 years. Since its beginnings, which was around 1980, there have been over 1,000 randomized control trials of ACT. And that means these have been scientific studies where participants are either assigned to you get an ACT intervention group, or you don't. You get some kind of control or other treatment. This has been administered in person, but also online in a variety of formats. It has been adapted to people with a variety of psychiatric and neurological conditions, including stroke and aphasia, um, which I think feels very exciting, and newer. I think something that was missing historically in psychology for a long time. Um, I find ACT to be a really great approach with a lot of clients that I work with and without brain injury and aphasia. Um, but I'll specifically talk a little bit about adapting for aphasia. But I started administering ACT when I was in our community clinic with, young adults, college students. Yeah, kind of focused in, everyone has different goals for therapy, but I've found it to be very effective with pretty much everyone that I've worked on it with. Um, so the framework of ACT, my favorite way to explain ACT when people ask me what I do, is giving this bus of life metaphor. So first, just to say, ACT is this what we know as a third wave therapy. So many of you have probably heard of cognitive behavioral therapy. Um, some of you may have not. It's the most evidence-based psychology treatment that we have. Um, and ACT is sort of this third wave, like building upon cognitive behavioral therapy. And instead of trying to change or take away your negative thoughts, it's focused on how you relate to your thoughts. So it's focused on kind of changing your relationship with them. Um, so again, yeah, the goal is not to eliminate negative thoughts, but sort of reframe, right? So thinking about not how do I get rid of my pain, which maybe you have a condition that your pain is not really going to go away. But instead thinking, how can I live a meaningful life while it is here? And I think part of the reason I found this to be so impactful for people with brain injury and aphasia or in recovery is that, you work really hard in therapy. You do all of these things. You're on medications, you work on having a sleep routine. And there are a lot of things that, you put a lot of work in, right? But ultimately, recovery can be a little bit out of your control. And so I think it has been a very meaningful shift in thinking to think about what can I still do, and what is in my control. Um, so the bus of life metaphor, is kind of essentially saying you are the driver of your bus of life. There are a lot of passengers on your bus. But you, as the driver, cannot control who comes on your bus. So you're just headed to your destination. Um, Passengers are all around the bus, right? Are you going to allow them to distract you from driving to your destination? Or are you just going to kind of tell them they can say whatever they want, but you're focused on your destination? So the metaphor here is thinking about how we experience thoughts and feelings as we go through life, right? So some of these passengers or thoughts and feelings can be kind of quiet. They can be comforting. They can be positive. And some can be much less positive, and maybe try to dictate where you're headed or your life choices. And that's something that we don't want to happen, right? So when we think about ACT, we think about this idea that symptoms are a natural part of life. And a lot of therapies are focused on symptom reduction. So how do we get rid of this sadness that you're feeling? Which can be very effective. But I think what ACT does a great job at is kind of embracing that you're going to be feeling a lot of positive and negative things throughout your life, and that's natural. But if we can figure out how you can control your bus and have all of these thoughts and feelings in the back, um, your symptoms, you'll hopefully be feeling better. Um, Part of also what I love about this concept is that I think as humans, it's really hard to control our thoughts. Um, when I initially introduce ACT, I often say, us as humans, we make hundreds of choices a day, right? So I'm choosing to move my finger right now. Maybe I'm choosing where I'm going to live tomorrow, right? So there's like a variety of small and big decisions that we make all the time. And it can be really hard to say, like, Sachi, just don't think about this anymore, right? So I typically tell clients, you're going to sit in front of me and I'm going to start a timer for 30 seconds. And I want you to not think about a purple unicorn. Ready, go. Okay, I won't make you go through the whole 30 seconds, but the point being, it might be kind of hard to not think about a purple unicorn now, right? So there are all these thoughts. Why did Sachi say purple unicorn? Ooh, that could be kind of a fun animal to see in real life. But it's hard to kind of make your mind just shut things off. And so I think it's really nice to have a framework where we can, welcome thoughts that are both bad and good, but also learn how to still kind of lead your life choices with them. Okay. So I'll go a little bit into some framework here if it's interesting to some people. I won't spend too long on it. Um, but ACT was kind of built on what we call this triflex or triangle model. And it's all about thinking flexibly is kind of the main like ground of ACT is kind of how do we think more flexibly about situations that we're in. So the three points of the triangle, the first one is just being present. Um, and this is kind of all about noticing what's happening right now, um, without without judgment, right? So just be mindful about what you're noticing that is happening with you or your thoughts right now. Um, the second part is this idea of opening up. And so we talk a lot about this concept of unhooking from our thoughts. I think that we are very, I'll say the word fused with our thoughts as humans. Some examples of some negative ones. I'll never be who I was. Nobody understands me. What if the stroke had never happened? And the idea of ACT is that, yeah, these thoughts may or may not be true, right? So the idea isn't to, I never want you to have these thoughts again. The idea is, yes, you're going to have these thoughts, and that's hard. And maybe they're true and maybe they're not. But how do we help you to make choices to be doing, what matters to you in your life? And ACT is filled with analogies. Sometimes people are like, please stop. I don't like these analogies you're giving me. And sometimes people love them. Another one I like to use a lot, talking about unhooking from our thoughts, is this kind of tug of war analogy. So you're on one side holding a rope, and there's a scary monster on the other side. And this monster is representing your anxiety and your self-doubt, and maybe, painful memories, all of these things. And you guys keep on playing tug of war, right? And you're noticing you're exhausted. The monster is a lot larger than you. It's pulling and pulling, and you're doing the same. and you become totally exhausted. And you're just focused now on beating this monster rather than actually focusing on anything else you want or where you want to go. So we kind of like to talk about this as this idea of, you don't want to be pouring all of your energy into this tug of war and letting this monster dictate your life. And it's draining your time and it's draining your focus. Okay. And the other thing ACT talks a lot about is values. Um, so I just like to, initial session with clients, I like to say, who and what are important to you? What kind of life do you want to be building? Right? So who should I know about? What should I know about that is important to you? And that will come up in sessions. So we just, we want to be talking about connecting you to parts of your life that you want to be connected to. And I like to say goals are achieved, and values are directions. So they're kind of just ongoing. So, if someone has an example of, I want to go outside more, right? And they say, I'm going to go on a walk 2 times until I see you again. I'm like, great, that's a great goal. I love it. When you do that, we'll check it off the list and we'll have a new goal. Um, but it seems like your value here is connecting with nature and the outdoors, and that's not something we're going to check off, right? So you can go on your 2 walks, you can come back to me, and I'm not going to say connected with nature, check, right? But that's a value. That's something that you feel means a lot to you, and contributes to this meaningful life of yours. We also like to talk a lot about workability. So is what you're doing making your life meaningful? Um, if it is, great. Like, that's awesome. Sometimes, it's something like avoidance. And I'm like, is avoidance workable for you? Is that helping you? And people are like, yeah, right now I need to avoid this thing. And that's fine. If it's not workable, if it's something that's functionally getting in the way of where you want to be, that's not a reason to be judging yourself or beating yourself up, but maybe a signal for you and I to explore what else might work. Okay, and why do I love ACT for aphasia? Here's another myth debunked for you. Psychological therapy requires verbal fluency. This is just not true. It is historically how psychology has been developed, but there are a number of ways where this is changing. You don't need to tell me what you're thinking to be thinking, is what I tell people all the time. And people kind of laugh at me, but it's true. I mean, you're all thinking right now. It doesn't matter if you're telling me about it or not. I'm oftentimes thinking, and I'm not telling people what I'm thinking about either, right? ACT can very easily use visual materials or images, communication supports, things like drawings, gestures, and also can involve families or caregivers. I put a star here in case this is something people want to talk about later, like questions around creating space for families in mental health therapy. Traditionally, psychology was very much, created to have this individual space for folks, right? To have this private time. Now we know we have family counseling, couples counseling, all of these things. Um, and sometimes people choose to have, their families or partners in the room with them. We know that about half of family members also end up developing some level of depression after a loved one's stroke. This is pretty recent known data. So obviously, families and caregivers are carrying their own grief and emotional load. So I think there are ways to balance having this like individual private space while also creating space for families. which is something I've been learning about, I think, more recently. Um, and lastly, I just love that ACT is really based on this question of what matters to an individual, right? So, staying connected to grandchildren, maintaining independence, returning to a hobby or a creative outlet, or being part of a community, right? So these are all things that you don't need to verbally communicate with me necessarily and are very life-altering things that we can do and work on, to help your brain feel better. Okay, this is a lot. I did not put this slide here, intending for you to read all of it, but more just to show you, or walk you through some sort of initial work that I typically do with clients, starting in ACT. So I first like to start on this bottom right hand, quadrant, when I just ask who and what are important to you. So this is actually a real example that is de-identified, but from a few years ago. So, my client told me these family members are important. I have these three friends that I care a lot about. I care about having purpose. I care about safety, and that means in my home space and also financially. And I really care about pleasure. So I love art, I love history, I love nature, all of these things. So then we move into kind of what gets in the way. Um, so, this client said psychological diagnoses, right? So depression, anxiety, OCD, but also things like confidence, worry, this kind of self-image. Um, and after we go through this, you can imagine maybe, this is pretty heavy work, I would say generally. Filling out something like this typically takes 2 to 3 sessions, and it sometimes brings up really heavy emotions for people. Um, you know, Humans like to talk about themselves, but it's really hard to really deeply reflect on ourselves, I think. And so after this point, I typically like to ask, okay, you just told me all of these barriers, right? So what shows up for you, and gets in the way of prioritizing your values? Um, So then I ask, are these barriers workable things? So what do you do, to help cope with some of these bottom things, right? So what do you do when you have anxiety or when you're feeling worry? Okay, I shut down. I read. I procrastinate. And like I said, this is a perfect example of, okay, avoidance comes in many forms. If that avoidance is going to comfort you for a little while, that's okay with me. Like, that's cool. But if that avoidance means, you're shutting down, you're not talking to people for a day, it's, functionally debilitating for you, that's when this becomes an issue. Um, And then, lastly, we kind of talk about, what do you want to be doing to move towards things you care about? And this entailed breaking down tasks further, leaving the house. Um, this client really wanted to learn a new thing every day. She was like, that just makes me so excited. And I'm like, great. Like she got, a fact app on her phone, and that was something that was meaningful. Um, and contributed to this, value of pleasure. So as you can see, this requires a lot of flexibility in thinking. Um, I have these kind of silly symbols on here because I talk about, spiraling of thoughts and digging ourselves in a hole. But it kind of it I think this is a really great, initial framework, into thinking about what's important to you and also what happens when you feel really hooked or fused with your thoughts, right? Um, and so, for people with aphasia specifically, sometimes, a lot of times, what's important and what feels like is missing is, connection, right? And opportunities to communicate. But there are these barriers of wanting to avoid these moments of embarrassment or frustration or feeling overwhelmed. And so then we can talk about values, right? Like what's important to you, like taking that effort and connecting with someone. Or is it avoiding a situation for a little while? So yeah, it's meant to kind of be a very flexible form of therapy and also I think really emphasizes not judging what you're thinking about, which is important and hard. And you can also imagine it is very easy to use icons for these things too, which is really nice instead of the words. Okay, so another piece of treatment, which some of you may have heard about, is called behavioral activation. This is probably like the maybe one of the most evidence-based treatments we have for like depression and anxiety and a few different psychological disorders. Um, and it's really thinking about just doing more of what matters to you. So you can see, since I'm loving talking to you about cycles today, we see someone with inactivity, which can lead to depression and so on, right? So feeling inactive, feeling depressed, which, ties to a lack of desire to do things and so on and so forth, right? We're going through this cycle again and again. Behavioral activation is just this idea of doing more of what matters to you. So you're going to read a book twice a week. You're going to call a friend. You're going to go on a walk, right? And these things sound simple. And sometimes people will be like, this feels kind of like, are you really telling me to do this? And I hear that. I mean, I totally hear that. And I think this is not the only thing we work on, but it sometimes is can be all someone needs to really feel like they are having some meaning in their life again. Um, and I think doing more of what matters to you feels really hard at the beginning, but then becomes really self-reinforcing. Um, and you can kind of, you begin to really feel better about yourself. Like I said, I think oftentimes as clinicians, we really struggle with these questions of where a client's symptoms are coming from. Um, so is it neurobiology related? Is this an injury? Is it neurodegenerative? Is this an adjustment period? Or is this client depressed, right? So are they feeling this hopelessness and this deep sadness that really magnifies this cycle? Um, and again, I would encourage people to think about the fact that yes, it is interesting for treatment purposes, but again, it doesn't really matter in terms of what we're going to prescribe to you, I guess. Um, so yeah, again, you can see here even like there are large themes in treatment that are really important to us. The reality is we'll probably never really know the cause of what you're feeling, right? I mean, people feel situational anxiety and depression. Um, Stress can trigger it, injury can trigger it. Do we know the combination? Probably not, and that's okay. Okay, so I'm almost done with my slides here. To end, I am going to provide you two quotes that I think were very meaningful to me from patients and that I've heard, a number of people say before. The first one being, I stopped waiting to get better. Um, First of all, I think this is heavy. Um, and I think upon first read, can be read as, almost this like giving up on something. And it was totally not that. I think this was a really great way to frame the importance of focusing on the now, and what's in our control now instead of just waiting for something to happen further along the road that's going to maybe make us feel better. Um, I think for clinicians in the room, the number one question we get all the time is what will recovery look like? And very frustratingly for patients and families and for us, we don't really know, right? So research is great, and we know a lot more than we used to, and it's really cool. And we can, if you have a stroke in a certain area of your brain, it's likely that you would have XYZ symptoms, things like that. And that's really cool that we know that. Um, but generally for recovery, it can look a lot of different ways. And, it can be surprising a lot of the time. And recovery can mean a full return to previous function. And it can also mean building a meaningful life that looks a little bit different, and finding things that are just as important to you. I think both of these are very real experiences and they're very hard in their own ways, right? So even returning to previous function, what does that look like from now until then? Or what is the time between then, right? And not returning to previous function can also be really hard. It is hard, right? And kind of um, the flexibility involved in kind of rebuilding and readjusting, and re-navigating is really hard. But I think the waiting game of waiting for something else to happen or waiting for this magic leap in your recovery, can be a really huge barrier to starting treatment and feeling better. Okay, and then lastly, I actually think I heard Denise say this maybe in a talk a couple of years ago, but we are still the same person. We just do things a little bit different. So it's again kind of tied to this idea of, I guess, the acceptance framework, right? And I always, I typically have a lot of conversations with my clients that have had a brain injury about, my old self, and this is what I used to be, and this was my personality, but I'm not like that anymore. And I think I really try to encourage clients to think, you're still yourself. But again, yeah, things are a little bit different, and that's not always easy to accept. But again, there are a lot of ways to work through and form what you want these differences to really look like and entail, and find a lot of meaning in them. Okay. And lastly, we know that there are things that support mental health, especially after brain injury. Um, So movement and exercise, activities you love, or kind of those values that I talked about. Connection with others. I oftentimes do some mindfulness work in my practice, but that can look like faith or gratitude work. Sometimes it kind of all looks the same and people prefer one name or over the other. Um, and this sort of flexibility in thinking. And so I think for us as clinicians, this is also a challenge, but also for patients and families. Maybe let's think about adjustment as kind of this longer process again, right? So stopping expecting that we're going to be adjusted and re-navigated in this unreasonably short amount of time after thinking about what you and your brain went through. Um, and in terms of flexibility, thinking just about adapting things, a lot of things can be adapted. I have, clients who are in wheelchairs now and who used to love fitness, and that's really hard, but there are alternatives for a lot of things, right? And again, it doesn't mean we don't feel this grief around things. It doesn't mean that, we can't be sad about this new normal or this kind of new phase. But it does mean, there are all of these opportunities to focus on this rebuilding in ways that are important to you. And I also put a shameless plug for this podcast called Brain Friends, which is on the left side. I don't know how many of you have heard of it, but this is led by a stroke survivor named Angie, who is amazing, and was also started by a dear friend of mine who is no longer with us, but Dr. Celeste Gatson. They're both amazing, and there is actually a episode about mental health and brain injury. I think it focuses also a little bit on how, speech pathologists and other clinicians can be involved. And there are a number of other really, really awesome episodes focused on aphasia, which include like health disparities in aphasia and stroke research. Like neuropsych assessment, brain plasticity, all of these cool things. I see some reactions to this. Feel free to comment after. And okay, yes, that was my plug. I'm happy to answer any questions. My last thing was asking for help, which we know is really important. And I think brings us full circle since that's a lot of what this organization is about. Um, and I will, now take any questions, and my email is here too if people prefer that.
Hello, everybody. Again, thank you, Sachi. You've done an amazing job, and I really appreciate your presentation. We all found it very helpful and very educational, and mental health is a very strong area that I think that people are finally taking it serious, that it's not just our physical disability, it is our mental health piece that needs to be addressed. So thank you. I am going to thank you all for attending. This has been a great session. This recording will be notified to you as soon as we've completed all our sessions. So I'm going to pass this over to Kate, and she'll let us know what's going on next.
Wonderful. Thanks, everybody. I think the content today was so helpful. Sachi, thank you so much for dedicating your time to join us this morning. And I appreciate everyone's insights, questions, and shared resources in the discussion as well. Next week on Saturday, June 13th, we will be having another candid discussion, but this time talking about how brain injury can affect things like intimacy in our relationships on both physical and emotional level. And so we'll be having Dr. Laura Wolford joining us, who is a speech language pathologist and also a clinical researcher that delves into rekindling intimacy with aphasia. So we hope you all can join us next week. Bring your partners if you'd like. And we're really looking forward to that discussion as well. As Denise mentioned, if you have registered for this conference or this session today, you are registered for all of the sessions for the remainder of the month. And we use the same link each weekend. So you should be all set with that. If you are a professional who joined us this morning, I put the certificate of completion in the chat and you can download that. If you have any questions or you missed it, you can also reach out to me or Denise or anyone at Just Ask, and we will put you in touch with the certificate of completion. All right,
Thank you.
everyone.
Oh, let's thank
Have,
let's thank our sponsors.
oh, yes,
Thank
sorry.
you.
Go ahead.
Thank you.
I thank our sponsors from the Rhode Island Department of Health. Really couldn't do this without their help and their support. And I'd also like to thank the help me with that word there, Kay. I'm having word finding issues. It is nursing placement and health concept.
Yes, I believe so. Sorry, Denise, I don't have it in
That's
front of
right.
me.
So thank you all. Without our sponsors, we couldn't keep doing this free. 8 years and still doing this, and we've never had to charge anybody for any of the services here at Just Ask. So let's keep it strong. Thank you all.
Thank you all so much.
Thank you.
You were
Thank
really
you.
awesome. It was very fun.